Good morning, everyone. Does this sound good? Yes? Yes. This is my first time in Houston, and I have to tell you, I'm a little disappointed. I'm a little disappointed because I had hoped to come down and see the Rockets playing, because I don't much care for the Golden State Warriors at this point in time, and I thought I'd come down and catch a basketball game, so that's why I'm a little bit disappointed. As Jim said, we will provide you with PowerPoint if you need it. You can email me and you'll have it at the end, and I will be happy to send you the PowerPoint so you don't have to take pictures, although I love having my picture taken, and you don't have to take notes because everything that I'm saying will be on the video and also available. So I want to talk today mostly about the fact that there are two issues, and I'm going to address both of them. The first issue is that physicians don't understand the disease. So you're out there and you're looking at the internet and you're doing your research and you're doing your homework and you're working very hard to educate yourselves. And then you go into the doctor and say, I found this video, I found this article, and they look at you like you're talking another language. So we're trying diligently to educate doctors, and the best way right now that we're educating doctors is by educating you to educate the doctors. The second thing that I want to talk about today is the fact that there are many people, and I've seen over 1,500 people with this disorder, who believe that the answer to the disorder is another pill, and it's not. I can't help anyone who can't help themselves. So we're going to talk about both of those things, and I'm going to give you the opportunity today to be further educated about the fact that CRPS is not just a disease of the arms and legs. And I'm going to do that with a little bit of Sherlockian wisdom, and I'm going to tell you again that we look but we don't see, and so we're going to start with this. And I don't know if you can see this in the back, but hopefully you can, and I'm going to read it for you. It said, Holmes and Watson are on a camping trip. In the middle of the night, Holmes wakes up and gives Dr. Watson a nudge. Watson, he says, look up at the sky and tell me what you see. Watson says, I see 1,000,000 stars, Holmes. And Holmes says, what do you conclude from that, Watson? And Watson thinks for a moment, and he says, well, astronomically, it tells me that there are millions of galaxies and potentially billions of planets. Astrologically, I see that Saturn is in Leo. Horologically, I deduce that the time is approximately 3:15. Meteorologically, I suspect that we have a beautiful day tomorrow. Theologically, I see that God is all-powerful and we are small and insignificant. What does it tell you, Holmes? And Holmes looks at Watson and says, Watson, you idiot, someone has stolen our tent. We look, but we don't see. All right, so CRPS was all of these things, causalgia, Sudex atrophy, and my favorite, reflex sympathetic dystrophy, because when I started, it was reflex sympathetic dystrophy. And sometimes, and Jim cringes when I do this, I slip back into using that term. And we understand that there are different types, and you know all this, so I'm not going to tell you, I hope, what you don't know today. So complex regional pain syndrome is a neuropathic inflammatory pain disorder characterized by severe pain that extends beyond the injured area and is disproportionate to the inciting event. Disproportionate to the inciting event. And this is a problem. This is a problem especially in medical legal cases, because the lawyers and the medical community and the insurance people think you're making it up. We're trying to make money. That's why we're complaining about this pain. It was a simple injury. You should have been better a long time ago. And this is why we talk about disproportionate to the inciting event. Autonomic dysregulation, edema, not always. Movement disorders and atrophy and dystrophy. If you're active, you don't have atrophy. Do not let someone tell you that you do not have the disorder because you don't have any one or more of these. I have a patient who has no pain. She has a movement disorder and nothing else. Okay, so the Budapest criteria was created by Norm Harden and Stephen Brule and a bunch of other people in Budapest, Hungary, so that we could look and say, these are the criteria that you have to have in order to make a diagnosis. This is great in a medical legal setting. It is great for people who don't understand. It is great for people who are kind of not exactly sure. And we have provided certain criteria that need to be established, and they fall into the categories of subjective and objective. Subjective, that which you complain about. Objective, that which we as clinicians can see. But it starts with continuing pain, which is disproportionate to the inciting event. Let's talk for a minute about the inciting event. You don't have to be in a car accident. You don't have to fall down. You don't have to be injured by something dropping on you. The inciting event could be a needle stuck in your arm. I had a woman who was a professional seamstress. She got a bobbin needle in her finger. In a year, she was in a wheelchair. It does not have to be a major trauma. It has to be a traumatic event. And we have tremendous latitude to a traumatic event because of what I just told you. Sensory, those things that you feel with the sensory system, hyperalgesia, allodynia, excessive reactions to either stimuli that should be painful or stimuli that should not. Temperature differences, color differences, and again, I will reiterate, you don't have to have all of them. You have to have one symptom in 3 of the 4. Edema or sweating changes, and we'll see that in a little bit. Motor changes, motor dysfunction, tremor, weakness, dystonia, and we'll look at pictures as we go along. And then the signs, meaning that I or my clinical cohorts will be able to see this when we examine you at a given time. All right? But the bottom one is really important. There is no other diagnosis that better explains the signs and symptoms. Now, you've probably heard the term rule out. Do not ever believe that every doctor understands what they're dealing with. They teach you in medical school first year. I don't know what that is, but I know what it isn't. So we're coming in the back door. Okay? If I ask you sitting out there to pick a number between 1 and 5, you have a 20% chance of getting it right. If I ask you to pick a number between 1 and 5 and tell you it's not 1, 2, 3, or 4, you're really smart. And that's what we're doing. Because a negative diagnostic test frequently gives you information that's useful because it's taking one of those criteria away. And when the dust settles, if it isn't anything else, and you're meeting the criteria, it falls into number 4. Okay? Exacerbating factor, stress, first and foremost. Okay? Somebody comes into my office, they are generally under control, and they're a mess. First question, what happened at home? Always. Cold, change in barometric pressure. It is not the weather being hot or cold. It's the change from hot to cold that sets people off. Infections, especially dental, humidity, poor diet, vaccinations. I could do an hour on vaccinations. We're not going to get into that. Aluminum toxins, such as underarm deodorants with aluminum in them, prescription medications, candida, yeast infections in the stomach, Lyme disease, which people don't think about, and many more. But stress is paramount. Okay? So every so often you'll see one of these things that I throw in there because, as Jim said, I'm a pseudo-Sherlockian scholar, and I read Sherlock Holmes all the time, and I've been since I was young, mostly because it made me a better doctor. And if you're wondering why that is, because if you read Sherlock Holmes, the information is always there, unlike Agatha Christie. It's always available. You just have to see it. Okay, so diagnostic testing-wise, you've had the MRIs, you've had the CAT scans, you've had the X-rays, and God forbid you've had the EMGs. And the doctor looks at you and says, they're all normal. Well, why are they normal? Because anatomically, you don't have a fracture. There's nothing wrong that's going to show on the CAT scan. The MRI is looking at the nerves, and what they're looking at is the structural anatomy of the nerves. They're fine, okay? And those of you who have had the misfortune to have electrodiagnostic testing will know that that's a test of motor function of the nerve. Remember, the nerves have 2 functions. They have a motor function and a sensory function. The motor function allows you to move. The sensory function allows you to feel. Okay? This is a sensory disorder. It is not a motor disorder. So you can have a motor function test that is normal and still have CRPS. How many people in the room know what thermography is? Okay, more than usual. Great. So the nice thing about thermography is, one, it is infrared imaging, which means there is no contact. The human body emits heat. You sit next to somebody, they are warm, you know that they are warm. We're able to image the heat. And we're doing that by looking at the sympathetic nervous system. My God, we have a test of the sympathetic nervous system in a disease that affects the sympathetic nervous system. Why are we not doing more thermography? I could do an hour on that too, but it is a political decision that has been made in this country to not do more thermography. The bottom line, and you're going to see this in a minute, is that I have a non-invasive tool with no radiation, with no contact, with no pain, with no tubes, that will tell me if your sympathetic nervous system is functioning properly. So if you have a question, find a thermographer, and if you can't find one, send me an email and I'll find you one. Okay? So here's a couple of case histories. A 19-year-old male, about 6'4" and 220 pounds, comes into my office with his parent one day, and he has pain right underneath the rib cage, right at the bottom of the rib cage on the right-hand side. And it is so severe that he is breathing like a fish out of water. I mean, this kid really cannot breathe. And he has no history of trauma. He has no other diseases. He just has this pain. Well, my first thought, when I examined him, is that he had what we call a rib lesion, which people mistakenly call costochondritis, that he had an irritation of the nerve that sat underneath the rib. Well, we did everything we could possibly do. We looked around and we could not make him better. I put a needle in the rib. Okay, it didn't help. We put him on topical medications, it didn't help. And after a while, I began to wonder why this kid was complaining of pain. Because I'm human too. I wonder if people are making things up. Okay, and I really, honest to God, thought, well, maybe he wants to stay out of school. He doesn't really want to do this. He's fighting with his parents, all those things that go through people's mind. And then I took this thermographic picture, okay, and I got a problem because that's where the area of the pain was, and it doesn't match this one. It doesn't match at all. He's got these two hot spots over here that don't match the other side. And I'm saying, well, this doesn't make any sense. And now I'm starting to believe that he really has something wrong with him. And then I did it in black and white. Okay, this is his navel, so that's not it. But here's this hot spot. This is exactly where he's complaining of pain. Well, now I know he's telling me the truth, because you can't make this up. And so we tried everything. I mean, we had all kinds of different things tried, and nothing worked. And then I started taking more pictures. This is actually a picture of his back. And for those of you who've never seen a thermogram before, this and this are supposed to look alike, and they don't. And then I took a picture of his legs. And lo and behold, he's got this, okay? And I'm going, wow, we got a problem here. And then I took a picture of his hands, and I found this. And then we made a mistake, and an interventional pain doctor decided to stick a needle in his upper back because he thought that this was coming from a spot in his upper back, and lo and behold, we just set him off like crazy. So I had a kid who has one pain right here, who has full-blown CRPS, that nothing worked on. Case 2, 45-year-old man is working at a construction site on work boot, steps on a nail. The nail goes through the boot, through the sock, and through his foot. And it went up into an area in the foot where he went to a podiatrist who decided that he should have surgery. So the podiatrist operates on him and does what he has to do, and then he winds up with a Morton's neuroma, and he couldn't walk. And he had been a patient of mine, left the practice because of insurance reasons, called me on the phone and said, there's something wrong with me. And so when he came in, I took a picture of him. Now remember, this kid stepped on a nail in his foot. This is his left leg. And again, for those of you who've never seen a thermogram before, these two legs are supposed to look alike. And you notice a couple of things. This doesn't look like this doesn't look like this. But look how the diameter of his leg is here. All right? And I took another picture of his hands, and I got this. And he called me on the phone one day, and he said to me, I'm in the emergency room. And I said, why? He said, I've been throwing up for a week. And they tell me there's nothing wrong. I went to a doctor, and also the disease spread through his body from stepping on a nail in his foot. And again, if you don't have visual evidence of things, sometimes you don't believe. So it's a reason to do thermography. It is a reason not only for corroboration, it is a reason for medical legal, it is a reason to convince the insurance company, those folks that allegedly are paying your bills, to continue treatment, to go a little bit farther. I put the entire set of slides up in front of a judge in a courtroom in order to get this paid. So it is necessary in today's American society to have what lawyers call objective medical evidence. Objective medical evidence means we don't believe you, prove it. I mean, it's just as simple as that. And if you have a negative MRI and you have a negative EMG and you have a negative CAT scan and you have a negative X-ray and your laboratory parameters are all normal, what do you got? You got sitting at home without any treatment fighting the insurance companies that are not willing to pay for something that they don't want to pay for, because once this disease is diagnosed, they've got you on the hook forever. Okay, it's not like a fracture. Hey, 6 weeks later, the fracture's healed, we did a little physical therapy, fine. You now have a lifelong disorder, and they don't want to be paying for lifelong disorders. They want you out of the system. Okay, so let's talk about some of the things. A couple of things. Vasomotor changes, one leg with hair, one leg without hair. I don't know if you can see in the back, but this is an interesting story. This is a person who came into my office. I had a person who came into my office, and he'd come the first time, and he was sitting on the table, and I was sitting in front of him being the diligent doctor, and I had my little percussion hammer in my hand, and I wasn't looking at him, and when I looked down, there was a drop of water on his leg. So I looked up because I thought it was a leak in the ceiling, and there wasn't, and I went back to hit him again, and there was another drop of water on his leg, and I looked up again, and there still wasn't a leak in the ceiling, and I looked at his face, and I was dealing with Two-Face from Batman. One side of his face was soaking wet and dripping sweat, and the other side was completely dry. Literally as if someone had drawn a line down the center of his face. I said, well, I don't think I have to hit you with a percussion hammer because I know what's wrong. Okay, dystonia, and there are different kinds of dystonia. This is facial, this is not. And those of you who either have dystonia or know someone who has dystonia, it is what it is. I had a woman with a dystonic hand who was it was not only dystonic, but it was also fire engine red. And she had gone to 6 doctors as a matter of a lawsuit. 3 of the doctors were sent by her lawyer, 3 doctors at the insurance company, and all 6 doctors said it was as bad a case of dystonia, CRPS, as they'd ever seen, and they sent her to a 7th doctor who said it was all in her head. Now, I know all of you out there going, I've heard that before, okay? So the lawyer sent me the report of the doctor, and he said, I want you to rebut this report. And I said, I'm not going to rebut this report. And he said, why? I said, because I'm going to take the day off from work when the case goes to court. I want to sit in the courtroom. I only want you to ask him 2 questions. First question, okay, did her hand look like this when you saw her? He's only got 2 choices, yes and no. The only 2 choices he's got. If his answer is yes, your next question is, how come 7 other doctors saw her and said it was the worst case of CRPS they ever saw, and you said it was in her head? And if his answer is no, you say, how come 7 other doctors saw it exactly this way and you didn't? Because they didn't like the guy, he was local, and I thought, well, this is great because we'll get him out of the business, but it never made it to court, so I never got my day to see him just that way. This young lady, there's a person attached to this leg. This young lady actually came in to the office from Tel Aviv, Israel, to get ketamine infusions. This is the infusion chair, and she was asleep, and this was the way her foot was, okay? This was her dystonic foot. She was asleep, and this is what her foot looked like. 5 days later of the ketamine, before and after. Neurogenic edema. Now, understand there's different types of edema. You get edema or swelling from injury. You twist your ankle, it swells up. Okay, you have heart failure, you have cardiac edema. Neurogenic edema, such as this, where the legs are profoundly swollen, is not going to respond to diuretics, to water pills. You can take the whole bottle, it's not going to make a difference. It is coming from malfunctioning of the nervous system. The best treatment is elevation. Please, folks, elevation does not mean legs off the floor, and it doesn't mean above your head or above your heart, because nobody will sit in that position. I don't care if you have no disease, that's an unhuman position to live in. So 2 quick things. 1, pretend that your foot has a drop of water on it. You want the leg high enough that the water runs this way. It's real simple. And don't elevate your feet on pillows because you will kick the pillows out in the middle of the night. Elevate the bed. Get bricks, cinder blocks, whatever. Lift the bed up 3 or 4 inches. Then it doesn't matter how you lay in the bed because the whole bed is up. Simple stuff. This is a lady that comes into my office. When her knee turns that way, I know she's in a flare. This unfortunate young woman has this on her arms. You can't see it on her arms, and she is always this way as a result of her CRPS. And when it gets worse, they begin to get dry and scaly and flake. Okay. This is actually a post picture. If I had shown you the picture pre-ketamine, his legs would have been about this big. This is just stasis dermatitis because the nerve endings are telling the blood vessels what to do wrong, and so there's not enough blood flow. Remember, the legs are the farthest place from the heart, and so this is the way his legs look all the time. I now have 2 patients like this. If you looked at this woman, your first thought would be that she was pregnant. My first thought would have been that she was pregnant, except she had a hysterectomy, so that's not likely. And so what happened was that her stomach, from this, and this is not gastroparesis, her stomach blew up like this. And we did every diagnostic test that I could think of. We did upper and lower endoscopies. We did gastric emptying studies. We even went into her belly surgically to look around and see what was there. And there was no anatomical problem. This is the way she looks, and it just keeps getting bigger. And we treated her every which way, and the only thing that worked for her was we put her into the hospital, we put an epidural catheter in her back for 5 days, and her stomach became half of that. So we were treating the CRPS invasively to get her stomach to go down. And when it went down, it stayed down because we gave her some ketamine behind it. Unfortunately, after about 4 months, it began to re-increase again, and we're going to have to put her back in the hospital. This was the first one I ever saw like this. I now have a second one that looks almost identical to this, and there's no anatomic lesion. And everybody just scratches their head and said, "What do you want me to do for her?" This is a woman. I added this slide at the last minute. This woman has been coming in to see me for a long time. And I looked at her hands and said, well, it's clear to me that you have rheumatoid arthritis. I mean, this is a pretty easy diagnosis. Except she doesn't. She has no rheumatoid factors. She has no blood work that's consistent with that. She has no rheumatoid changes on her x-ray, and the rheumatologist says she doesn't have rheumatoid arthritis. Well, that's good enough for me. Her hands are like this from her CRPS. And we are trying to convince the interventional pain doctors that we work with to get a sympathetic nerve block someplace just to see what happens to her hands, because I don't know the answer to that question. But this is something relatively new. And this is one of 2 pictures that you will see of neurodermatitis. Okay, they look almost like little acne pimples that people have. And you go to the doctor, mostly family doctors, who go, I don't know what it is, and they come and go, and there's no rhyme or reason for it. It doesn't necessarily mean that somebody's in a flare. It doesn't have to be anything of this sort, but they start out looking like that. At the beginning, we talked about seeing but not observing, and really it is clear. Okay, so the next phase of this is to talk about the fact that let's forget for the moment about arms and legs. Let's talk about other things that happen to people with this disorder. Now, unenlightened physicians say it's not possible for you to have fill in the blank. Why is it not possible for you to have stomach or urinary or gynecological system? This is a disease of the nervous system. The nervous system controls everything. So why can't we have what we're going to talk about? All right? Peptic ulcer disease, irritable bowel syndromes, nausea and vomiting, gastric irritation. It is gastroparesis in non-diabetics. Gastroparesis, for those of you who don't know, is the sluggish emptying of the stomach and the process into the bowel to do the normal bowel habits. It normally happens in diabetics. However, if the stomach is not functioning properly because of the nervous system malfunction, you get gastroparesis. And it's simple enough to test. You do what they call a gastric emptying study. Gastric emptying study means you go to the x-ray department, they give you a really crappy food to eat, Okay, and then they measure how long it takes to get through the digestive system. And most times it will show up abnormal. What do I see? I see somebody comes in and says, every time I eat, I throw up. It doesn't matter what I eat. I have a couple of mouthfuls, I throw up. Well, there's got to be a reason for that. And the reason for that is that the food is getting into the stomach, but it's not getting out of the stomach. And so when you go to eat, because the mind says it's lunchtime, and so you eat, there's no place to go. There's no room at the inn. So it's coming back up. And the best treatment that we have right now is it says to put Botox into the pyloric sphincter. You can do it through an endoscope. You don't have to have surgery. What you do is you put some Botox in. It relaxes the outlet area. And the food begins to leave. And when the food begins to leave, you get back into more normal. It doesn't last a lot of times. And a couple of times a year you have to do it. But it's an easy, and it's certainly better than throwing up every meal. I have a lot of people that have pancreatitis. Pancreatitis is a disease of alcoholics. It's a disease of trauma. It's a disease of people that have diabetes. It's a disease of people with pancreatic disorders. But what about somebody who doesn't have any of those things? Dysphagia, difficulty swallowing, indigestion, irritable bowel syndrome, constipation that may or may not be related to opioid uses, biliary dyskinesia, stomach problems because it's not working right and the gallbladder is not working properly. Urinary problems, incontinence, dysuria, pain on urination, inability or difficulty to void. And people say, oh, you have interstitial cystitis. No, you have a neurogenic bladder. Okay? And so you have to look at it from that. Sometimes Botox injections work if you have difficulty. Sometimes hospital-based infusions work with lumbar epidural catheters. You've got to look at the big picture. A urologist who does not understand CRPS will say you have interstitial cystitis, and you may. But if we go back to that 1, 2, 3, 4, or 5 rule-out thing that I talked about earlier, interstitial cystitis is a pretty significant and straightforward disease. And if it doesn't meet the criteria and you have CRPS, look at it from a different perspective. Most times, if you treat the CRPS, the interstitial cystitis / urinary retention problem gets better. Vertigo is generally positional. A lot of people drop their blood pressure, so you've got to look at that. Okay, meclizine, which is antivert, makes the vertigo tolerable, but if anybody's ever taken meclizine or Antivert, it makes you very tired. So you're trading one for the other. You've got to figure out where the vertigo is coming from. Syncope is basically passing out. It is, the article at the bottom says, syncope is common in patients, especially with lower limb involvement. Okay, so here's my favorite one. A 44-year-old female is involved in a motor vehicle accident. She has CRPS, gets worse from the motor vehicle accident. And what happens is, the strange way this accident happened was she was in a small town and they had a parade through the town. And on the parade there was a boat. It was sitting on a trailer. And the boat had those flags to let people know what it was. And somehow or other, we haven't ever figured out, the flag hit her and pushed her head off, and then she fell down and landed on her arm. And so she wound up with a stretch injury to the brachial plexus on top of her CRPS. And she would walk down the hall of my office and fall down. I mean, she would just fall down. She wasn't tripping on anything. She wasn't passing out. She would just, like somebody pulled the plug, she would fall down. And so we did a brain MRI, we did an EEG, we did laboratory testing, we did a carotid ultrasound. Everything came back normal. And we were really at wit's end, and sometimes in the middle of the night at 3 o'clock in the morning, I wake up with these things that tell me this because I get that way. And I sent her for a carotid ultrasound, an ultrasound to the neck, just to measure blood flow in the neck. And the technician, who I happen to know, called me on the phone and said, I already did one of these. And I said, here's what I want you to do. I want you to do the ultrasound. And then after you do the ultrasound, I want you to turn her head to the side, and I want you to check the blood flow on one side. And then I want you to turn her head all the way to the other side. I want you to check the blood flow again. And 10 minutes later, I got a phone call from the technician who said, she's on the floor. At which time I smiled. I wasn't smiling because she was on the floor, but that 3 o'clock in the morning thing happened. What happened was that when she stretched her plexus, okay, as people will do, she began to hold her head this way to reduce the pain. In doing so, she was crimping her carotid artery on this side. So she had less blood flow. She had plenty of blood flow over here. But every time she turned her head this way, she didn't have enough blood flow over here, and down she went. So we put her in a cervical collar to keep her head up, and she stopped falling down. Headaches, generally greater occipital nerve headaches. They come from the back of the head up this way. And they're pretty easy to understand. Tell me about the headache. It starts here and it goes like this. Okay, and if you block the greater occipital nerves, and it's easy to do. I don't do much injection work, but that one I do, and I use nothing but homeopathic agents. I don't use Novocaine and cortisone because homeopathics work. And I get 6 months out of a homeopathic injection right into the occipital nerve, and the headaches go away. Tension headaches, no reason for a CRPS patient to be tense. Okay, visual disturbances, double vision, blurred vision, ocular migraines, where you see little shooting things, vision loss, field cuts, photophobia, very, very common. The inability to go out in bright lights or sunlight because the lights are so painful. I had a girl come into my office with 3 pairs of sunglasses on because of the overhead lights bother her. Doesn't take too long to figure out what's going on. Burning of the eyes is relatively new, and we're trying to find a way to get ketamine in an ophthalmologic preparation to help this because we haven't been able to find a way to help the burning in the eyes. Intravenous ketamine helps, but it doesn't hold. Okay, otorhinolaryngolic, fancy word for ear, nose, and throat. Otophobia, loud noises. Turn the stereo down. Okay, and it's the bass on the stereo that sets people off. So if you've got kids and they've cranked that bass up, there's a problem. Okay, and sometimes, here's an interesting word, vibration. I have had people report that they're sitting in a car and the vibration from the stereo in the next car is setting them off. Apparently more than one person in here is agreeing with me. Hoarseness. Hoarseness comes from an irritation of the branchial plexus. Ever get up in the morning in your horse and go, oh, I'm getting a cold, and an hour later it's gone? Okay, or you're talking and right in the middle of a conversation, you start to get hoarse, and then it goes away. That's because the plexus, that branchial, not brachial, branchial plexus, and sometimes people think that it's coming from something else, but it's not. It just comes and goes, and there's no rhyme or reason for it again. Dental. I have 22-year-olds with no teeth. We've had all their teeth. I have a woman right now that I'm seeing who brushed her teeth literally 5 to 6 times a day, in the morning, after every meal, after every snack, and before she went to bed at night. And in a period of 6 months, she went from having perfectly white, beautiful teeth to everything being gray and black. I mean, her teeth literally in front of my eyes rotted out of her mouth. There is no other reason than what this disease did. Now, there are other things. Poor oral hygiene, not her case, poor nutrition, loss of saliva and dry mouth. All of these things can contribute to it, but it starts with the disease. There's some more of that neurodermatitis that I talked about. Here's one you probably never heard of. Anybody hear of Derkham's disease? One person. This looks like a lipoma. Lipoma is a fatty tumor, totally benign. Tumor is really a bad word, but that's what this is. And that's what these are. They are painful lipomas. I have one patient that has these, and they crop up, and they are incredibly painful for her. You can't run a tissue across these things without her wincing in pain. There was actually one doctor that I found who's either in Colorado or Arizona or someplace who has an association of Derkham's disease and has a protocol and a plan, and in her case, the ketamine helps control the CRPS, which helps control the Derkham's disease. But that's what it looks like. It looks just like every other lipoma, except they hurt. Morton's neuromas. Anybody in the room with a Morton's neuroma ever? Did you have it removed? Good, don't. Okay? You don't ever want Morton's neuromas injected or removed. Okay? What do you do with them when they hurt? You find someone who can freeze them, who can do cryosurgery on them. And put a cryosurgical probe in, freeze them, and generally you can improve the situation, you can minimize the pain, and you don't run the risk of extending this into CRPS. The young man that I talked about who had the needle going through his foot ultimately wound up having the Morton's neuroma removed because we couldn't do anything else. So we loaded him up with ketamine in the operating room, and we took his neuroma out, and we were able to get some success without making the CRPS worse, but it doesn't always happen that way. So if somebody tells you you have a Morton's neuroma and they want to stick a needle and say thank you very much and put your shoes on and walk away. Cognitive dysfunction, short-term memory loss, everybody, okay? I can tell you what I wore to my senior prom 30 years ago, but I can't tell you where I put my car keys this morning. Sound familiar? Yep, okay. Some people think it's medication related, but it happens in people with no medication. Now, part of the reason is that people with this disease begin to withdraw themselves from the workforce. And what happens is that the brain, like every other part of the body, is if you don't use it, you lose it. So you're not out there going to work every day. You're not fighting with your boss. You're not talking to your employers. You're not on the phone all day. And the brain is not getting stimulated like it used to get stimulated, and it gets lazy. That's not the only reason, but it's part of the reason, and it's the part that you can control. Get on a computer, okay, find things to do. Play word games, do things that force you to think. Talk to people, go out and have a cup of coffee with somebody. Whatever it takes, get the brain reactivated. And please don't tell me reading, because that doesn't reactivate the brain, because if you forget something, you just go back and look at it again. And God forbid, please don't tell me watching television, because there is nothing more mindless than today's television, unless you're watching Jeopardy or something like that where your brain is forced to think. So find a way to get the brain active. Shortness of breath, inability to take a deep breath, neurogenic edema we talked about, muscle weakness and atrophy, adrenal, hormonal imbalances, one that you probably don't know, bruising in an area that you didn't injure, lethargy, fatigue, sleep disturbance, all of these things. Now, I want to talk for a minute, and I'm going to come back to it a little bit later, but I want to emphasize the importance of this, adrenal, thyroid, and hormonal balance, and I'm going to talk about that in a little bit, because my guess is that those of you that are actively treating the disease, very, very few will raise their hands when I ask the question, how many of you have doctors that are looking at your hormones, your adrenals, and your endocrine system? Not many, but good for you, okay? So this is a big thing of mine. Genetics is a big thing of mine. I don't know any other way to tell you this, and I have 21 families with more than one person with CRPS. I use this as an example. Back in the days, I'm from New Jersey, so we have Atlantic City casinos, and they used to have money in the slot machines. Now it's all paper, but they used to have money in the slot machines. And this woman was at the casino, and the guy had the money cart, and he lost control of it going down a ramp, and it hit her in the thigh. And she wound up with CRPS in the leg that moved up to the arm. And we treated her CRPS, and that's not the issue here. Her sister was a police officer in southern New Jersey who was driving in a police car when the police car was broadsided by another car. Now, you want to talk about bad luck. If you're going to hit a car, do you really want to hit a police car? But the police car came and hit her, and the armrest from the door hit her in the side of her thigh in the same exact place that her sister had been hit by the money cart, and she wound up with the same disease that moved in the same direction. Now, you can call that bizarre, you can call that whatever you want, but I've got 20 families, and we know that there is a gene in the body that predisposes people to this disorder. And when I said I wanted to do a genetic study, the genetic people said, that's great, it's going to cost you $1 million, literally $1 million. And I've not yet found a benefactor that wanted to offer me the $1 million to do the study, but if any of you know somebody, please put them in touch with me, and we'll do the genetic study, but it's very real. Medications, and I'll let you look at the list while I talk to you about these two, antidepressants and anti-anxiety agents. I have a question for everybody in the room that has CRPS, and just by show of hands. I have the Getson one-question depression test. This is the question. I am depressed because, fill in the blank. Now, is there anyone in the room, and please raise your hand if there is, who cannot answer the question, I am depressed because? Okay. I'm depressed because whatever the reason is, I have pain, my life sucks, whatever it happens to be. So why would anybody believe that taking an antidepressant drug, this is a pet peeve of mine, I warn you in advance, Why would anybody believe that an antidepressant drug is going to fix the mood disorder that comes from a reason? I'm depressed because I hurt. Good, if I take your pain away, you're not depressed anymore. Treat the problem. Don't treat the depression, because when you treat the depression, what you're doing is you're numbifying the brain. So you wind up getting one of those drugs that you then need more of, that then doesn't work, and you get into trouble. And again, I was invited here so you get my opinions. Don't anybody take Cymbalta. Please. Okay? It is harder to come off Cymbalta than it is to come off of morphine. And if you don't believe me, type in the word Cymbalta lawsuit on your computer and watch the class action suit that's going on in this country for that reason. Cymbalta is chemically similar to LSD. So you can't come off the drug without worrying that 6 months down the road you're going to have flashbacks. And every new patient that comes into my office has or is on one of two drugs. Cymbalta. Want to guess what the other one is? Come on. Gabapentin. Everybody's on gabapentin. Okay? And I encourage you to take gabapentin if you were a female, want to be fat and stupid. Because that's what it does. Okay? So, and here's the other thing. Depression and anxiety are two sides of the same thing. So if I make you less depressed, I then make you more anxious, which means I have to give you a benzo to make you less anxious, which makes you more depressed, which then means I have to give you more antidepressant, and now we're doing this. Bad idea. Bad idea. Here's some things you probably never heard of. Mixilotine, which is oral lidocaine. Capsaicin, which is a cream. Amantadine. Anybody know what amantadine is? Okay. Amantadine is a drug for type 2 influenza virus, actually. It's been around since the 60s. It has no side effects, except that it's an anti-flu drug, so if you take it, you never get the flu. But amantadine anecdotally works in some people with this disease, and it's a real safe drug. Dextromethorphan is the DM in cough medicine. And again, it's one of those kind of things that has really no side effects except you don't cough, and maybe it works. And also understand that there are different kinds of pain in this disease. You have muscle pain, you have inflammatory pain, you have the deep burning pain, you have the piercing pain. Well, why take more morphine, just for the sake, if you have a headache? Just take something for the headache. I had a woman come into my office one day, had all this medicine, had this horrible headache. And she said, I took 3 Percocet this morning, I can't get the headache to go away. And I said, why would you think it would go away? So I went in the other room and I gave her a Furoset and I said, I'll be back in 15 minutes. And I came back in 15 minutes, she said, my headache's going like it was a mystery. Okay. Take what you need and as little as possible. And we'll talk about that in a minute too. You've probably heard the term opioid-induced hyperalgesia. Quick story, a woman in my office is on 400 micrograms of fentanyl, 4 patches. Incredible dose. I fought with this woman, I said, you cannot take 400 micrograms of this drug. So we're going to take it away. I took her to 375 and then 350 and then 325 and 300, and lo and behold, she didn't have any more pain at 300 than she had at 400. And we waited a month or two and then we came down again. And she got to 200 and she had the same pain that she had on 400. No shock to me. When she got to 175, her pain flared up. Right about then, her husband decided he was going to leave her and walk out, packed his bags and left. And about 4 months later, on 200, she decided that she wasn't going to live this way anymore. So what she did was, her mother took her kids for a weekend, and I didn't find this out until after, and she pulled the 2 patches off and detoxed herself. And fortunately, she didn't die. She just laid on the floor of the bathroom for 4 days and threw up. And lo and behold, on 0, she had the same pain she had on 400. There are people who actually have more pain on opioids than off them. And I'll get back to that again in a little bit. For those of you who want to know about ketamine, you are not getting a ketamine lecture here today. Okay. I've been doing ketamine longer than anybody in the United States. Okay. I will be happy to talk afterward for anybody that wants to talk to me about ketamine. But this is the one thing that I do want to tell you. Dr. Schwartzman, my mentor in this situation, and I and a couple of other people put this case report together. I had 22 people involved in this, and of the 22 people that got ketamine intraoperatively, from dental extractions to podiatry, not one of them extended the disease. So I tell my patients, if you are going to have a surgical procedure, you must have ketamine during the procedure. How much depends on the length of the procedure, not the size of the patient. Generally in the vicinity of 100 to 125 milligrams of ketamine is sufficient to act as a buffer. And I call the anesthesia people and I tell them, and I tell the patients, if they're not going to give you ketamine, go home. You'll find somebody else who will. And as a general rule, anesthesiologists don't fight me because after all, ketamine is an intraoperative anesthetic drug. I'm also smart enough to know not to tell anesthesiologists what to do. So I say to them, look, give her whatever you want. Just make sure she's got 100 milligrams of ketamine with whatever you want to give her. I make nice with them and they stay nice to me. So that's what we talk about there, okay? The purpose of being here today, my reason for coming here today is to talk to you, to give you all that, but also to give you all this. It is really, really, really important that the patient and the family be a part of this. Okay, I can't do this alone. I like to think I'm good at what I do. Okay, I'm tired of writing prescriptions. We need to talk about things to help you help you. When you walk out of that office, you need to do things to help yourself. If you're going to go home and sit there and say, why did this have to happen to me? We're never going to get anywhere. So we're going to talk about diet and lifestyle. We're going to talk about going gluten-free. We're going to talk about quitting smoking. We're going to talk about quitting drinking. We're basically going to talk about quitting everything you enjoy doing, okay? And then we're also going to talk about things like Reiki and manipulation and acupuncture and other things, okay? And for those people who say, I can't afford certain things, that's self-explanatory. Okay, so I want to show you, and Reiki is energy medicine. People familiar with Reiki? Okay, is non-hands-on energy medicine. My wife is a Reiki master. So she brought this patient in, and on the left-hand side, you see a thermographic images of a woman with a brachial plexus injury on the right side. This is her right hand, this is her left hand. Okay, and so here's what we did. We took the pictures, and then she spent an hour doing a Reiki treatment on her, and then we took these pictures. So this is the pre-Reiki picture after a week of doing that, and this is the post-Reiki picture. Now, I understand you've not seen thermograms before, but you can see that this doesn't look like this, and certainly the circled areas don't. And then you get to here and you see how much more symmetrical it is with no change in anything other than the Reiki treatment. After 5 weeks of doing Reiki, that's the pre and post. Same woman, same story, nothing changes. That's 5 weeks of Reiki. Okay, so there's a whole list of here, organic foods, eliminate processed foods, eliminate household cleaners. Those of you who watch the news heard the deal in California with Monsanto recently, this week, and Roundup, the most toxic product in the entire world. Okay. If you're out and you're fortunate enough to be out in the garden, why would you want to inhale chemicals that are going to make you sick? You already have a problem. Stay away from toxic chemicals. Buy household cleaning products that are healthy. Drink water. Stay away from synthetic hormones. The body doesn't like synthetic. The body likes natural. Anybody in the room that's on Synthroid, Synthroid means synthetic thyroid. They make all natural thyroid. They make Nature-Throid. They make Armour Thyroid. Get your doctor to change you off the Synthroid. It's not real, okay? Positive outlooks, we're going to talk about that in a bit. Appropriate diet, exercise, find a healthy avenue, maintain healthy relationships, find something that makes you feel good. Let me go back one, I lost one there. Okay. NutraSweet, anything with aspartame in it, horrible. Okay, MSG, sugar, caffeine, gluten, we talked about dairy. Here's one that you might not know about, nightshades, tomatoes, potatoes, and eggplant. Nightshades set off CRPS. Okay, we talked about that. All right, gluten sensitivity is actually an autoimmune condition. And so it can affect your brain, your heart, your joints, your digestive tract. This one, the brain. So you need to treat the cause. Treat the gluten. Now, these are 55 diseases out of the New England Journal of Medicine that can be caused by eating gluten. I'm going to spend 1 minute talking to you about fibromyalgia. Any of you who have watched any of my videos know how I feel about fibromyalgia. And those of you who haven't, you're going to hear it right now. Fibromyalgia in my world does not exist. If you look at the National Fibromyalgia website and you read the description of fibromyalgia, and you look at the RSD website and you read the RSD definition, they're the same definition. Okay. Fibromyalgia in my world is a subsect of CRPS. And there are other people who have written articles to that thing. Do it for yourself. Don't take my word for it. There is an interlinking in these diseases. When I give lectures to doctors, I'm careful not to do this because then 3 guys come up and go, you know what you're talking about. Okay. But I'm telling you that it is exactly the same disease. So if disease is associated with gluten or fibromyalgia, then by association they're also CRPS. And so this is a gluten-free diet. Now, how many people in here are willing to give up beer, food additives, pasta, processed meats, cakes and pies, candy, cereal, cookies, French fries, gravy, etc. But we eat. Not anymore. And then there's that E word, exercise. Okay, doesn't matter. There's always something you can do. There's always some kind of exercise. People say to me, what kind of exercise should I do? I say, anything you can do, as long as you're doing it. If you can't walk, do arm exercises. If your legs still work, do stretches. There's always something you can do. Mobility is paramount, okay? And if you can get outside for 15, 20 minutes a day. Get outside without sunscreens for 15 minutes. Get outside at a time when the sun is not at its hottest. Sunlight, 15 to 20 minutes, gives you more vitamin D than you can get in any pill. Detoxify, just do something to work up a sweat. Listen, if you're in pain, it isn't hard to work up a sweat. But do it. Okay, infrared saunas, good infrared saunas. We just go spend 10 or 15 minutes. Drink lots of water. Take deep breaths. Make sure that you don't get bound up from either inactivity or medication. Remember now, we don't want you constipated. The best laxative in the world is water because it softens the bowels. All right? Neurotransmitters, clinical messengers. Neurotransmitters, very, very important. There are more neurotransmitters in your gut than in your brain. There are ways to test for neurotransmitters. Neurotransmitters, I don't have the list. Neurotransmitters are things like serotonin and GABA and epinephrine and norepinephrine. They are all in those things that we're ruining with antidepressants. SSRI, serotonin is the second S. Okay. Get somebody to test your neurotransmitters. You do it with saliva. And replace what you are deficient in. Don't take antidepressants. If you need serotonin, take serotonin. It's available, it's inexpensive, and it's not by prescription. And eat healthy, because this is where most of the neurotransmitters are. This talks to this. I talked to you earlier about hormones. When I do blood tests on people, and urine tests, I look at cortisol, I look at all the female and male hormones. Because if there's a hormonal disturbance, everything's out of whack. It's not just somebody who's mentally in disarray because of hormone imbalance. If there's something wrong, fix the problem. We're not talking about rocket science here. I got off the plane, I saw this thing in the airport yesterday. It says not rocket science. Oh yeah, it is. It isn't. This is simple stuff. But we're living in 21st century American medicine, which is get in, get done, get out. Hi, I have 30 seconds to talk to you. What do you want to say? It doesn't work that way. Fix the problem. B vitamins. Another thing I test for. Test all the B vitamins. Be careful of B6, okay? Excessive B6 has actually been shown to create pain. It's why you have to watch. There's the myth of B12. I get more B12, I get more energy. That's an old wives' tale. However, B12 is made and absorbed in the gut. And so if your gut health isn't good, your absorption of B12 isn't good. Okay. So the brain requires lots of B vitamins for repair and permanent maintenance of proper brain neurotransmitter and adrenal function. Stress causes B vitamins to be quickly depleted. And as we've already said, there's no reason to have stress if you have CRPS or live with somebody. Okay, basic supplements in my office: fish oil, omega-3s, probiotics, multivitamins if you don't eat right, vitamin D. Again, if you get outside, you don't need this. Magnesium and calcium stops leg cramps at night. Digestive enzymes. The standard process people, and I have no financial response to anybody. The standard process people make a product called Zypan. Okay, it is retail about $13 a month. Zypan is a digestive enzyme. It is an enzyme that breaks down the foods and allows for better absorption of what you eat. It smells awful. It has a horrible taste to it. You get over it in a day. It is the best product I have ever found. And again, I have no financial interest here. I take this. Right? I don't have CRPS. I take this. It's wonderful. It helps you digest your food better. Now 5-HTP, DLPA. 5-HTP acts as a painkiller and antidepressant. DLPA has opiate agonist qualities. Methionine reduces pain. Fish oil acts like ibuprofen. B6, zinc, and manganese aid in pain relief. 5 things that will help you with pain that don't require a prescription, that don't constipate you, that don't make you mentally stupid. Now I have a slide, and I think it's the next slide, and if it is, I just want you to listen to the words, okay, because it's really, really important, and this is a key thing for me.
All I know is that first, you've got to get mad. You've got to say, I'm a human being. God damn it. My life has value. So, I want you to get up now. I want all of you to get up out of your chairs. I want you to get up right now and go to the window, open it, and stick your head out and yell, I'm as mad as hell, and I'm not going to take this anymore!
That came from the movie Network in the 1970s, if you don't recognize it. And here is why I put this up here. Because I have a patient who has been a patient of mine for a very long time, and she's now 60 years old, and she was involved in a motor vehicle accident that was her fault. And she came in to see me, and I'd known her, like I said, for about 30 years. And I said, well, what are you going to do? And she said, I'm going to stay home for the rest of my life because I've worked long and hard enough. And I said to her, you have 4 kids that you started having when you were 18 years old, so you didn't even start working until you were in your late 30s. And so you worked for about 20 years. And you're going to spend the rest of your life staying home. And she said, that's it. I'm going to apply for a Medicare card. I'm coming here every month, let you give me medicine, and I'm going to stay home for the rest of my life. And that really bothered me a lot because that was kind of at this end of the thing. It doesn't matter what disease you have. If you have a chronic disease, you need to be a part of this, okay? You need to get angry. You don't need to get angry at the universe. You need to get angry enough to stand up and say, I'm mad as hell and I'm not going to take it anymore. You need to be a part of the system. And how are you going to do that? Well, you need to make smart choices, okay? What do you mean by smart choices? Here's what smart choice is. I have a lady that comes in, she's got a dystonic arm, she's got CRPS, it's a problem. And I give her 10 days worth of ketamine, and by the end of the 10th day, her arm is not dystonic, the hands are not discolored, she's feeling good, she's happy, and she said, this is the best I felt in a couple of years. And she comes back on Monday for a booster treatment, and the arm is back up like this, and the head's down like this, and I took a look at her, and I thought, something wrong here, and I said, well, what happened? And I suspected she went deaf because she didn't answer me. But I said, what happened? And she said, and I said, no, what happened? And she said, well, I felt so good. I painted my daughter's room over the weekend. And I looked at her and I said, really? And I know that there are people in here who are going to resonate with what I'm saying. I felt so good. I didn't know when I was going to feel good again. So I took the opportunity to do something that I've wanted to do for a long time. And I see all the heads going like this. That's fine. Be smart. Okay? You can do things. I encourage you to do things. Be smart. Ask yourself a question. You won't see me again except videos and stuff. But pretend I'm standing in front of you and you're asking me this question. If I came to Dr. Getson and I said, this is what I did over the weekend, would he be screaming and yelling at me and telling me that I'm stupid? Because if the answer is yes, you probably shouldn't do it. There are ways to do things smart. Make smart choices. It's your life. It's not worth trading this for a week in bed. Number 2, don't own your disease. We are all responsible for saying, my RSD, CRPS flared up. It's not yours. Give it away. If you got an ex-husband or wife, give it to them. You don't want it, okay? It's all right to say, I'm having more pain today. And don't for 1 minute believe that the words that you use aren't important. If you don't believe me, get the video called The Secret, which talks about the things that you put out in the universe, turn around and come back at you. Be careful what you wish for. It's not yours. Don't own it. Okay? Educate yourself. Well, you're here, so you're doing that. But seriously, educate yourself. Read. Listen, look at articles. We've got the internet. I forget about that sometimes. I walked in a couple of weeks ago to see a patient. I went and put my hand out. I said, I'm Dr. Getson. She looked at me. She said, of course you are. I forget that people have videos and they look at them. But educating yourself also goes back to making smart choices. Because if you're on a chat room where people are sitting around going, oh, my life sucks, my life is terrible, get out. It's a smart choice. Surround yourself with people who are motivated to be better. I cannot tell you how many times, I'll probably tell you this 5 more times before I stop talking today, what you do and what you say helps you as much as what I prescribe or what I do. Because I'm not with you 23 hours a day. I may get an hour here and there. You're living with you. You're living with someone who either has the disease or you have the disease. You've got to change your life. Listen, if there's anybody in the room who's a diabetic, the first thing they tell you is lose weight. The second thing is exercise, and the third thing is watch what you eat. And then maybe you have to take some medicine. But the point is, if you don't do the first 3, it doesn't matter what the medicine is. You've got to lose weight. You've got to follow the diet. You've got to do this, because if you're not doing it, you're not going to get better. This is not CRPS. I don't care if you're hypertensive, diabetic, have high lipids. It doesn't matter. It's about participating in your own well-being. Remove toxic people from your life. You may have to get rid of a lot of your family. Seriously, you know, the problem is that families, when you look normal, it's tough. You look fine. Well, I'm not. You look fine. What's a diabetic look like? Looks like you and me. If I stood here and told you I was a diabetic, would you know if I was telling the truth or not? No. Okay? It doesn't matter how you look. Okay? Surround yourself with people who are going to be supportive. And if it's somebody that's there in your life on a full-time basis, educate them too. And if they're not willing to be educated, then maybe it's time to rethink that relationship. Okay? Take as little medicine as possible. I think you probably knew that one was coming at some point. I don't like medicines. Medicines, well, there are times that we need medication. I'm not going to deny it. There's not times that we necessarily need more medication. If you can make yourself better with supplements, if you can make yourself better with dietary changes, if you can make yourself better with physical therapy, make medicine the last resort. I've already told you how I feel about anti-anxiety agents and antidepressants and things like that. Take as little medicine as you can. Eat healthy. We've gone over that. Get outside. We've talked about that. And do not limit yourselves. There is no limit. Okay? There is no limit. what you're doing is self-limiting. Yes, I understand the disease. I mean, I do this every day. I see 10, 15 people a day that have CRPS. I understand. My mother will be 90 years old in October, has bilateral lower extremity, both legs, CRPS. She is almost 90 years old. She takes no medication. She drives her own car. She lives alone. She does her own food shopping. She does her own wash. And she plays mahjong with her other Jewish friends in the apartment building in which she lives. Okay? She takes no medication. Is she in pain? Yes. But she goes. And no, if you're having the question as to whether or not this is the reason I got into it, she got the CRPS after I started doing it. All right? Don't limit yourselves. But be smart about what you're pushing, because there's that balance between the top one and the bottom one. Because if you're painting that room, you're saying, I'm not limiting myself, but I'm spending 14 days in bed. Okay, that's not a smart choice. So a couple of people who did not limit themselves, Sammy Davis Jr., who after the car accident took his eye, and living in an age where there was tremendous amounts of racial discrimination, wrote an autobiography called Yes, I Can. South Pacific, which came out in the year that I was born, 1949, says, have a dream. You gotta have a dream. If you don't have a dream, how are you gonna make the dream come true? Some people today are calling it a bucket list, but a dream is a dream. It doesn't really much matter. Everybody has to have something that they want to do. Now, I am in no way, shape, or form comparing what I'm about to tell you to what you're experiencing sitting here, okay? But people have things that are really important. And if somebody had said to me 2 years ago, before you die, what is the one thing you want to do? I would have told them that I wanted to get to the Sherlock Holmes Museum in London. Now, I know that sounds kind of like a strange thing, but that was the most important thing in the world to me. I had nothing else on my list that I wanted to do to get to the Sherlock Holmes Museum in London, because I am so fanatic about that. And what happened is, let me come back to this.
An ancestor.
I got to the Sherlock Holmes Museum in London last year. But I want to go back to this. There's not a week that goes by in my office that I don't quote this from Kenny Rogers, okay? Smart choices. You got to know when to walk away. You got to know when to say, I can't do that. And you have to have people that respect your ability to do that. So when I do these lectures, and I'm going to take questions in a minute from anybody who has them, my lectures always end with the same phrase. And I found this next video, which is only about 5 seconds long, but I got a kick out of it, so I put it on there.
An ancestor of mine maintained that if you eliminate the impossible, whatever remains, however improbable, must be the truth.
When you eliminate the impossible, whatever remains, however improbable, must be the truth. Okay? Arthur Conan Doyle wrote that about Sherlock Holmes. There is nothing diagnostically about this disease that's impossible. Okay? You need to find a doctor who's willing to listen. You need to have a logical thought process. You need to be able to look at this and say, that's not enough for me. I need more. Okay? Every one of you in this room that has this disorder, by eating right, getting outside, doing all the things I've talked about for the last hour, will be better than you were when you walked into this room today. I am not telling you that you're going to go up to Boston and run the marathon. I'm not going to run it either. The bottom line here is you have to help me, and all those people like me help you. Because if you're not willing to do that, why should I? Now, one last thing. You're suffering from a problem which is that, as Mr. Broach talked about earlier, and as we're trying to do right now, we need to educate us. And I need your help educating us. I get emails every day from people, and I answer every one of them myself. I can't give people advice who are not part of my practice, because that's medical malpractice, but I can point them in right directions. And a lot of the direction is, hey, I need a doctor in Kankakee, Illinois who does this, and I send them to Jim because he knows somebody that's there. Right? It's about education and putting that education into practice, regardless of what the doctor's telling you. It's about just saying no when the medication that you're being prescribed doesn't resonate with you and doesn't feel right. It's a matter of going home and cleaning out the pantry and getting the right foods. It's a matter of getting outside. It's a matter of doing all the things that I spent this time talking today. I appreciate the opportunity to come and talk to groups, which is why I flew down here to do this. I appreciate you being here and sitting and listening to me. I will be happy to stay here now and answer any questions that you have. I think, no I don't, okay. I have, up at the top, is a website that says clever name for a website, drgetson.com. But it has a link, and emails come in to me, and I answer the emails. I wish you all good health. I wish you all to be better than you were 2 hours ago. And I thank you for coming.
Dr. Getson will not be here at 3:34 when we have questions, so I'd love to walk in the audience and give you the mic, but please don't make it personal, don't make it your life story. Okay, someone?
Dr. Getson, I just want to know, I saw Neurodronate up there, and and it had an asterisk beside it. Wanted to know if you've used it and what has been your clinical success.
My hearing isn't what it used to be, so I'm going to use an interpreter. I'm sorry?
Biophosphate that's
Right.
on clinical trials.
Okay, so the Neurodronate, here's the quick story about the biophosphates. Pamidronate, which was a drug released right after the 2001 or 2002, something like that. And it was a drug for bone cancer, and it didn't really do much. And then the Neurodronate study in Italy a few years ago was on patients with type 1 CRPS. There were, if memory serves me correctly, 21 people. And they were all short duration CRPS people, but the results were so positive that the Grunenthal folks decided to take it worldwide and have spent a tremendous amount of money studying Neurodronate. They've not completed the study. They're in another phase of the Neurodronate. It is a tremendously well-run study, and if you have the opportunity to be a participant, then I would suggest that you do that. Results are individual. It is, however, in my understanding, a delayed response. It's not like you're going to up and walk out of there and go, okay, I'm all better. And in my patient base, I've only had 3 or 4, so I can't tell you what the results are. One gentleman got a little bit better. The other 3 I can't tell you because the time frame isn't enough. But the study is worldwide, not only nationwide, and if you type in Neurodronate and Grunenthal, you can find the closest one, and they'll tell you whether you qualify or not.
It's also that you have to have onset less than 2 years, and that's a problem for many people with long-standing CRPS. Next.
Thank you. Hi, Dr. Getson.
Hello.
I'm Judana Cavallo, board-certified licensed acupuncturist with CRPS. I came down with it in the last semester of med school. That said, I have full-body CRPS with it in the eyes. I had 100% wonderful response to IVIG gamma globulin. It was taken away from me by my insurance company. We're presently right now in appeals trying to get it back after more than 2 years of not having it. My question to you is, since it is in my eyes, there's very little help for me in the medical community. I was just wondering if you had any ideas.
But we're asking about eyes. Did I hear it right, correct?
Yes.
Okay. I've had a couple of people, really up until the last year or so, I'd never seen anybody where they came in and complained about burning eyes. And so the hypersensitivity of the eyes, the photophobia, that's been pretty common, the double vision, the blurred vision. And I found that in those people, by treating the central process of the CRPS, I was able to help the double vision and the blurred vision, but not so much the burning of the eyes. So what we are doing right now is trying to find a compound pharmacy that will make for us a safe eye drop that has a little bit of ketamine in it. Okay, because I think that will ultimately help. So what I would say to you is, if you, before I leave today, leave me your name and email address or whatever, and if I find that, I will reach out to you and let you know what we have.
We're trying to find neuro-ophthalmologists who are interested in learning more about this syndrome.
I will say, Jim, also while you're walking, that I've had people to neuro-ophthalmologists who basically kind of toss their hands up in the air and say that they're really not sure they recognize what it is, but they're really not sure what to do about it. And it was, in fact, a neuro-ophthalmologist and myself that came up with the idea of trying to put some ketamine in a safe drop. The problem is putting that in a drop that isn't going to be harmful to the eye, but will be helpful for the eye, and finding a pharmacy that will compound that. And so far, this is just recent, it's maybe a month ago, but if you leave me the information, I will let you know if and when we do that.
Our next speaker is going to be a compound pharmacist.
Wonderful. then we'll ask him.
Hi. You spoke briefly about getting your neurotransmitters tested, and then I think you said you take serotonin for that. Can you tell us a little bit more about that? How do you test neurotransmitters, and is that actually what you said, take serotonin? No.
There are a number of labs around the country that do neurotransmitter testing. None that I'm aware of that accept conventional insurance, I tell you that at the front end. But there are a number of labs, and what happens is they do this with a urine and a sputum sample. And they analyze the neurotransmitters, some of which I put up there and some of which I talked about. And they will give you, or your doctor or whoever, they will give you a printout as to what you have maybe too much of, what you have too little of. And the companies actually analyze it beyond that. So for someone like me who says, okay, I'm not a chemist. What does this mean? What do we do? Does somebody need more of this or more of that? And they'll actually walk you through it. They have people on staff who are. So if you find someone who will do that, you can then purchase, whether it's serotonin or epinephrine or whatever it happens to be, and you're now taking a supplement specific to the problem that you're suffering from, as opposed to just taking kind of a shotgun thing.
And what kind of doctor would order a test like that?
Any doctor can. I mean, I'm in general practice. It's just a matter of going in and saying, okay, I found XYZ lab in Montana that does this, give them the information. The doctor has to sign up with the lab, which is free. And they get the test kits, they give you the test kit, you take it home, you mail it in, the results come back to the doctor. It's pretty straightforward and simple stuff.
You mentioned asking for ketamine for dental surgeries. Does it need to be the level of oral surgery, or do you need to look at it for just extractions or maybe cavity fillings or things like that?
Help me out, Jim.
He's asking about the extent of dental surgery, extractions, cleaning.
Right.
When do you need ketamine for?
You need ketamine for everything. Okay. If you're going to, even if you're going to have a single tooth extracted, many dentists in my area actually have ketamine in the office, and they'll take it up to 75 or 80 milligrams, which for a single tooth is sufficient. If somebody's going to have full dental extractions, I send them to the hospital, we put them to sleep in the operating room, and they do the extractions in the hospital room, because we can amp up the ketamine, and also at that point in time we can make sure that it's safer for them because they're monitored and things like that. But even the simplest thing, if you're going to have a single extraction, yes, and if you're going to have a root canal, don't. Just take the tooth out, because a root canal, again, a whole long story, but root canals leave lingering infections, and those lingering infections ultimately are toxic to the body. And I know this from a separate issue with thermographic testing. Root canals leave infection. And by the way, this has nothing to do with the lecture, but for you women in the office, in the room, 85% of all women diagnosed with breast cancer have at some point in time had a root canal on the same side of their mouth. 85% of women.
Hell out of our audience.
I wanted to know how you feel about spinal cord stimulators.
Okay, fair question. Well, I don't like them. I'm going to tell you why. In the rare event that I get someone who comes into the office that has one limb problem, okay, Mrs. Jones, your right arm is a problem. How's the rest of your body? It's fine. So if I made your right arm fine, you'd be perfect. You go back to work. Yeah, that to me is a spinal cord stimulator candidate. But when you get into all these things that you looked at today with internal organ stuff, when you get into all that, the spinal cord stimulator just doesn't work in people like that. It doesn't work if you have two arms or an arm and a leg. This is just my experience. I'm sure if you talk to 15 people, you're going to get 15 different answers. But in my experience, the only people that really do well with stimulators are people who have one limb problem. And by the way, okay, I'm sorry, Jim, I'm opinionated, and this is what it is. They don't do it right, okay? It's a blind procedure. What I mean by that is they put the stimulator in with you half awake, and they say, how do you feel? Okay, is it better, is it worse? Well, if your pain is at 20 on a 1 to 10 pain scale, anything is better. This is why you find people who have trials who do well, and they put the permanent in, it doesn't do so well. They should be putting spinal cord stimulators in with a thermographic camera, because when the lead is in the right place, the color of the limb changes. But I haven't been able to convince any of the companies that own spinal cord stimulators to listen to me, but I'm still trying.
Abbott's here today.
I hope they're listening. Somebody's listening.
And Dr. Wu will give another opinion.
Okay.
Thank you so much for all of the helpful information. That was unbelievable. The test that someone had mentioned earlier, is that the phentolamine test?
No.
Is that, so it's different than that? And
Yes.
would you recommend, I'm being told to go get that, but no one knows where or have ever heard of it.
Never done one.
A phentolamine test?
Never done a phentolamine test. I'm aware of it, okay? And I've been doing this now since 1980 something. Not only have I never done one, I've never even had a patient that I know that has had one done. So I can't give you enough information to answer your question.
Okay. Can I ask one more thing? I just wanted to ask, did you mention Dr. Larry Epstein? Is that the doctor that you mentioned previously in the slides?
Dr.
Epstein?
Larry Epstein?
Don't know the name.
Okay. And now, how do you feel about naltrexone?
Naltrexone.
Okay, naltrexone is an anti-opioid. It blocks the uptake of opioids, loosely speaking. The naltrexone seems to be very, very good at pain relief in some people in a single low dose, anywhere between 1.5 and 6 or 7.5 milligrams, taken, I prefer at dinner, some people take it at bedtime. It seems to work very, very well in some people. It's relatively innocuous, certainly much better than all those other pain things, not only because of less side effects and it being a healthier drug, but it's not an opioid. You can take it once a day. The other thing on that same line that I've had really good success with is medical marijuana in the states that permit medical marijuana. And CBD oil to that degree. I have a wonderful woman who for 12 years, lovely woman in her 60s, who has taken 4 Percocet a day of every week of every month for 12 years, and 1 month into CBD oil is off the Percocet. So don't belittle the value of CBD oil, which you can take orally or topically, and medical marijuana seems to work very well as well.
Okay. Another thing to know is a magic website is called PubMed, P-U-B-M-E-D, and it's a library of medicine, and you could just put in a search term, and you could put in your test and see what comes up, and it's great. Okay.
Real quick. You mentioned about vitamin B. So what is the good vitamin B to take?
Well, if you're going to take vitamin B, okay, find a reputable multiple B vitamin, a B complex.
No, did you say B or D?
B.
B, okay.
Right. Find a B complex, and don't buy it at Walmart. And I have nothing against Walmart, but make sure that you get it from a vitamin store, and not even a chain vitamin store. There's always these places that sell high quality stuff. Get a high quality B vitamin and take it, but be careful to have the levels of B monitored, because you can actually, as I said with B6, you can go in the wrong direction if you're taking too much. You get all the B vitamins you need if you're eating right. So if you eat a healthy diet, a well-balanced diet, you don't need to supplement the vitamins at all. But in the event that you need to supplement them, do it with a multiple B vitamin.
And also the gabapentin, so you're saying we shouldn't be taking gabapentin?
I've not understood, I truly don't understand why the first line of treatment for everybody that thinks they have neuropathic pain is gabapentin. I've not ever understood it. But it is. I mean, it's a reality. And while we're on the subject, this is something that makes me laugh. Someone will come in and say, I'll say, well, what are you taking? They say, well, I'm taking Lyrica. And I said, okay. They said, what would you take before? They said, well, I took gabapentin, but it didn't work, so the doctor put me on Lyrica. And I look and I say, well, to me, that's kind of like saying I don't like a Ford, but I'm going to drive a Lincoln. Because in essence, Lyrica is a second-generation gabapentin. I mean, that's what it is. And it doesn't make any sense. But it's a drug, and I wrote to the pharmaceutical company when Lyrica came out, and I said, is this going to put weight on people, and is it going to do the same thing? No, it's not, and I have it in writing, not going to do that. Baloney, okay, it does the same thing, so if gabapentin doesn't work, Lyrica's not going to work. There are people that it works for. I'm not going to stand here and tell you that nobody should take the drug. I'm just saying you have to sit and look at the thing. When I say to somebody, gabapentin's going to make you fat and stupid, which I do all the time, they look at me and go, well, nobody ever told me that 35 pounds ago. Oh, okay, well, did you wonder where those 35 pounds came from?
Dr. Chopra always says that when you're taking a new medicine, titrate up to what they think is the therapeutic dosage, 8 weeks. If it's not helping you, get the hell off it.
Or if it makes you fat and stupid sooner than that. Okay, sorry, go ahead.
Hi. Is there any genetic study? We're twins. She contracted RSD before I did, and now I have it. I have it on my left side. She has it more than, and I have it on my right side. She has it on her right side. I have it on my left side. I'm the oldest of the between us. So is there any genetic?
Yeah, I'll answer.
Well,
Okay.
before you say something.
We were just approached by a doctor in Connecticut that wants to do a genetic study with a geneticist. So we're going to be announcing it via our emails and website. That should happen soon.
Good, let me know. My first answer to you is 21 just became 22, okay? I see it all the time. I am not aware right now. There were articles, anecdotal articles in the literature. I'm hoping that what you have to do is really going to be terrific because it's there. The problem, by the way, okay, and that we're going to face as clinicians is that if I know that you have a sister and you have CRPS and I'm genetically testing her, what am I going to do about that? Okay, and that's something that we're going to have to address as clinicians. If we know that she's got the same gene that you do, and just in a situation of anybody else, what are we going to do about that other than jump on it if somebody gets injured? I mean, and that's been something I've been wrestling with all along too, but I'm hoping that we can figure something out here.
And these were two different cases. I was injected with a contaminated Synvisc injection, and she fell. So it's two totally different accidents, kind of.
But the same premise is there,
right.
That if you were sitting around as the second one along the line, sitting with that gene,
Right.
okay, it was just waiting to happen, and something to happen.
Okay, gotcha. To go back to the dental, I just had some dental stuff going on, and he wants to replace crowns. What would be a suggestion for that? Should I do ketamine infusions and have been doing them for 5 years? 5 years, I believe, and I'm now down to doing them one every 10 weeks. And I started out at...
I would say to you that there's two ways. Either get ketamine during the procedure,
Okay.
or have a treatment the day before and a treatment the day after.
Ooh, okay. Okay.
Either way.
Thank you.
And there are dentists, dental anesthesiologists, and we could help you find one in your area.
Twofold question. First of all, you didn't mention vitamin C. Curious about that. And also, what is the short-term and long-term expectation with ketamine infusions? Like, is it like an immediate response?
Jim, help me out on that because I'm not.
Okay. She's asking you, why did you not talk about vitamin C in short-term and long-term expectations for ketamine? Is it, in other words, is it down the rabbit hole? You have to do it forever.
Vitamin D?
Vitamin C.
C. I haven't done much with vitamin C in terms of immune system. There are people who come in and get vitamin C infusions basically for health. I've never experienced in my particular practice where vitamin C deficiency has been an issue where I've had to augment the vitamin C, except to help boost the immune system, because the immune system in CRPS is damaged unquestionably, and so there's certainly no reason not to do vitamin C. As far as ketamine is concerned, ketamine was never intended to cure CRPS. I mean, we got to kind of start with that. Ketamine was intended to improve people's lives. So the idea is to take someone who is out of control and make them better enough that they can do physical therapy, that they can do all the things that they can't do to help them help themselves. And I appreciate that you asked the question, because people come in and they think, I'm going to get ketamine, I'm going to be all better. And it's just not that way, although I will tell you that it does make people better. I've probably done 400 or 500 people. I don't know, I don't keep count, but I will tell you that probably close to 90% get some improvement from the ketamine. Now, some come every 2 weeks and some come every 6 months. It depends on the individual. But the idea is to get them to a point where they can then do more, okay? And along the way, with all this stuff, we're talking about the way they eat and the way they live and all these other kind of stuff. But if you're so bad that you can't go exercise, if you're so bad that you can't do the things you want to do, you can't get mobile, you can't get outside, that's really where ketamine works. It gets people better so that they can then help themselves. So short term, people start getting better in about 3 days the way I do it. Long term, 85–90% of people stay better with periodic boosters, provided that they don't get an infection, that sets them back, or they don't paint their kid's room or whatever it happens to be. But the long-term expectation is, and it's a bad analogy, so give me a little latitude here. To me, ketamine is to the CRPS patient what insulin is to a diabetic, in the sense that as long as you stay with it, it will allow you to do the kind of things you have to adjunctively to maintain your level of well-being. And I know I'm not equating them, but I think everybody understands what I'm saying here. Most people that stop the ketamine, okay, need to go back to it. Anybody who stops the insulin probably ultimately needs to go back to it. And so when I try and sell it to an insurance company and they don't understand why I'm doing repeated boosters, I'm saying I wouldn't stop insulin on diabetic. Why would I do this? And so I hope that answers your question.
And I think that the theme of our conference today is no one intervention works alone.
Is there a specific diet you like to recommend to help people get started?
A specific?
A particular anti-inflammatory diet?
No, it really isn't. I've had people try different things. I think there's a lot of really good anti-inflammatory. I think if you, let me back up a second. First thing, dietary-wise, is stop the gluten. Gluten goes first. Processed foods, but of course, because they all have gluten anyhow. Gluten, processed foods, sugar. And then do your homework, do your research, and find something that you like to read. There's a lot of them out there, and you start reading these, the excerpts on these, and you know who's for real and who's, full of crap in terms of what they're talking about. But the idea of getting on an anti-inflammatory diet, I was listening on my way here to a doctor who was talking about inflammation being the root of all evil, and really it is. I mean, theoretically, everybody who has any malady at all should be on an anti-inflammatory diet. It's not limited to the people in this room, but whatever feels good to you.
On our YouTube channel, we have at least 3 videos for nutritionists talking about diets for people with chronic pain. Okay, Dr. Getson, thank you.